we came up with a 5-step approach to help revise and predict elective procedures and make a forecast of them. The 5 steps involve, first of all, it's a data-driven approach, so assemble your data and prepare it for forecasting. Once we have the data, we're going to focus, first of all, on the elective procedure backlog, that set of procedures that were authorized but not delivered because of the suspension. How are you going to work through those, and what is that going to do to your operations within your facility? We could also layer in forecasts of new procedures as well into that process. Once we understood how you were going to work through the backlog, then we were going to look at clinical and operational consequences. Working through procedures required staffing and procurement, so that's one thing. Another thing is clinical delivery of care. We know from data that a delay in delivering care often leads to complications. Could be post-op infection or additional rehab necessary. What types of additional encounters were going to likely be necessary because of the delay in delivering care? When you have that understanding, now you've got a total understanding of how you're going to work through your backlog and how many encounters it's going to result in. You can layer in the financial implications and understand the financial results. And we've got a model now that we can use to understand and plan and make predictions. You don't want to deliver a model without giving people the ability to adjust to new circumstances, to do scenario modeling, et cetera. So we layered in the ability to evaluate consequences and make adjustments. We initially did this, as I said, in April and May of this year. We thought maybe it would be relevant to helping people through the summer. As Andy mentioned earlier, the circumstances have been dynamic enough that this has been a relevant topic for many months and probably will continue to be so throughout 2020. So let's walk through the 5 steps quickly, and then I'll show you a quick demo. First thing we need is data, and we need 2 types. Historic data, which we can learn from. The first thing we want to look at is a 3 to 5 year history of elective procedures claims by facility. When they were scheduled or when they were authorized, when they were scheduled, what types of procedures they were. We're going to learn from this to understand and identify patterns of how different procedures are scheduled and worked historically. If possible, we're also going to look for information about complications resulting from delay of care from your particular healthcare organization. That's the best way to learn. If that information isn't available, there is plenty of information in the literature that you can apply to that aspect of the model. So we're going to learn from history and we're going to apply it to the current circumstances. Each healthcare system has a backlog of pre-authorized surgeries that they're trying to work through, and most of them are trying to work through a backlog that began back in March. Additionally, you're constantly having changes in when facilities can open, what kind of procedures they can do, how many procedures you can do, et cetera. We want to try to get some information on that. We want to get some basic financial information, average reimbursements and cost per procedure, a little bit of AR data, how long does it take you to bill and collect, and then, if possible, get some forecast of more procedures that you expect to have to account for in the future. So once we've assembled data, we're going to learn about that backlog forecast. We're going to learn from history, go by procedure by procedure, facility by facility, and say, under normal circumstances, when you have a 60 to 90-day authorization window, how did you tend to schedule those procedures? Did you tend to schedule them early in the process, late, somewhere in the middle? Then we're going to realize that the window has changed, and it changes individual encounter by encounter. Everybody's got an authorization date, which is highly variable. The expiration dates are all over the place. Some go into 2020, some go into 2021. And then when you layer on the constraint as to when that procedure can actually start to be scheduled, like the facility opens, that authorization window changes even more. If we layer in to each individual scheduled or authorized procedure some of the history in terms of probability that we learn in that window, we can start to assemble a projection of how each individual facility is going to work through its backlog. You can allow authorization dates to vary, the authorization window to vary, the start dates of facilities and procedures, as well as constraints to vary. And we do give the ability to weight certain procedures. So if you want to say, let's get our joint replacements done first, if you want to vary capacity, we can only do so much at the particular facility. We have that layered into the model as well. Then there's the consequences of scheduling. As I said, the best way to learn is from each healthcare system's data, but if not, there is lots of data in the literature looking at the probability of a follow-up event or encounter having to be necessary because of a post-op infection or some type of follow-up treatment or additional weeks of rehab because of delaying care. This is all going to help us understand not just how you're going to work through your backlog, but all the unexpected events that come from working through that backlog with the delay in place. When we have an idea of overall how many procedures are going to work through, by looking at costs and reimbursements, then we can start to get basic projections of patient services revenue and profit and translate that into a projection of cash flow. And then finally, allow anything that you need to vary. If you're going to close or open facilities later, if you're going to start different procedures, if you're going to move things among facilities, allow you to evaluate the consequences of those adjustments.